So thank you very much for this opportunity. I know it's getting late in the day there, so I'm going to try to make this session as interactive as possible and focus on looking at solutions that already exist and show you some of what's there. That's what I look like. I've turned off my video in the hopes of maximizing my audio. If there are any problems as we go, let me know. I can switch to phone or something like that. Do ask questions as we go. This is your time, so if there's other things that you want me to explore or other answers that you'd like to have, feel free to ask. I'll leave it to UL to gatekeep and try to keep us kind of on time. My objectives for you today are to get a sense of some of the different ways that you can use FHIR and the scope that it has in terms of interoperability in healthcare. We're going to talk a little bit about FHIR persistence. So how do you store data when you're receiving it over FHIR? We'll talk a little bit about terminologies, so code systems and value sets, and how do you manage those, because they tend to be pretty important in the healthcare space. We're going to look at how do you create implementation guides and profiles and some of the other infrastructure resources that FHIR provides to let you document what it is that you're doing, or let others document what they want you to do and tell you to do in an RFP or regulation or stuff like that, and how to interpret those. And then just general approaches to leveraging the resources that are out there, whether that's the FHIR community, which you all talked a little bit about already, or just when you're trying to map your data, how do you do that in a way that increases the likelihood that you'll do it the same as others, and that you will have less custom coding to do and less arguing to do when it comes to making your system work with other people's. We're going to go through a number of different scenarios today, looking at existing systems or existing specifications. And for each one of those, I'll give you a little bit of an overview of what the heck the system is and where it came from and what it does. And then we'll use that as a jumping off point to explore some of the architectural questions triggered by that system. And things to think about as you design your own interfaces and solutions in the FHIR space. And for each one of those, I expect you'll have some of your own questions. So feel free to toss those into chat or just interrupt me, that works too. And we'll tackle those as we go. I don't know if we're going to get through every single one of these. It sort of depends on how many questions you ask, but we'll do our best to get through all of them. And certainly you'll have the slide deck that covers them all. The slide deck has a number of pages that are basically just links. I'm not going to present those. Instead, I'm going to use those as a jumping off point to dig into the internet and show you what exists there. And you can use those same links to go and explore yourselves, either in parallel or after the fact, to see more about what exists. By the way, these are not necessarily all going to be equal in terms of how long we spend on them. We're going to spend an awful lot of time on the very first slide or very first topic, and then we will spend less time on some of the others. So with that said, let's get underway. And let me get out of where I am so that we can progress. So before I do that, I'm going to talk a little bit about what I covered at the executive presentation. I think it was a week ago. I can't keep track of time anymore. We'll do that in about 30 seconds. So FHIR is global. It's used in pretty much all of the developing world and a large part of the developing world. There are solutions that are mandated by government in the US and other places, but lots and lots of adoption by both small and larger enterprises just because they find FHIR a desirable thing to do. This is Epic's App Orchard, 392 apps currently registered, all making use of the FHIR interface. And of course, there's equivalents in Cerner and Allscripts and various other EHRs. There are solutions to manage chronic care. There's solutions to integrate data from external sources. There's solutions to use mobile devices for nursing and care management. And there's solutions to provide overall viewpoint onto your patient population and where they're at. There is the iPhone Apple Health solution that has FHIR under the covers. So FHIR is very much in production in lots of places throughout the world, and we're going to explore some of those. So first is the Epic test server. There are test servers for most of the major EHR vendors, and those are open to the public. Anybody can come along and play and poke and see how they behave, which means that you can develop your solutions to integrate with those platforms without paying any fees, without applying for access. Some of them require you to have a user account, but that's given for free and right away. And those reflect what their existing EHR systems can do. And we're going to explore a number of things as part of looking at Epic solution. I picked theirs because I don't know, but you were the first name I thought of. We could have explored somebody else's instead. But we're going to talk about how do you decide what resources to use to expose in your own system and how to map those. We're going to take a look at the FHIR specification and help you to navigate that and understand what's there and how to read it. We're going to talk about what do you do when you have questions. What are the resources available and what are the best ways to ask and what are the best places to ask. We're going to look at extensions, which is a key part of FHIR. The FHIR base specification doesn't try to cover everything because we've learned from experience that trying to cover everything causes grief. We're going to look at identifiers and references. So how do you identify content in your own system and allow other people to reference it? And how do you point from one resource to another? We're going to talk about the general design of a FHIR server. What are the different pieces to a FHIR server? And how do you use a FHIR server to store data? We will talk about interface management because, of course, FHIR is an evolving standard. There have been several releases published so far, and there will be new ones in the future. How do you manage that without driving yourself crazy? And then we'll talk a little bit about security and privacy, and in particular, where to find guidance on all of that. So that's an awful lot of things to cover with just one solution, but it's sort of also our intro. So we're going to dive into a whole bunch of things as part of that. So let's stop with the slide deck and start with how do you navigate to find some of the public test servers. So this is the FHIR specification, hl7.org/FHIR. This is release 4, the current release. And if we scroll down to the bottom, one of the links in the middle here is public test servers and software. And anybody who wants to can add their particular server to this page. We've got the HL7 official reference implementation maintained by the author of FHIR, Graham Grave. But we've got tons of others, and they're not necessarily in any particular order. Some of them are open source, some of them are commercial, some of them are EHRs, and we're going to take a look at this one here, which is Epic's Sandbox. And so if we go there, they provide us with a nice list of all of their stuff. I'm going to log in because to get the play, they're going to want me to be logged in. But that's a pretty straightforward thing to do. Set up your own account, or you can use Google or something like that. And this is their list of all of the resources that they support, and all of the different versions that they support. So they have some resources that they support across all of the versions, and then some resources that they only support in newer versions, and some that they don't yet support in R4 But we're going to go take a look at patient, because it's healthcare and patients kind of matter. And specifically on patient search, I'm not quite sure why they have two different login layers, but we're going to log in here too. And for whatever reason, they refuse to remember my username, but they will let my password manager remember my password. And so this is their interface for searching for patients. And you can actually see the template that they use for patient search. Those are the various search parameters that they support. But let's take a look at it from a actually making it work perspective. So they have filled in a bunch of search criteria here. The way Epic works is you can't actually search across patients using their REST API. They have a bulk data API that lets you retrieve data across multiple patients, but their base RESTful API, you can only retrieve a single patient at once. So if you do this, if you run the search, you will get back a search result. We've got a single record, tells us where it's located, and then we've got all of our data. So we've got some information here about race and birth sex. We've got a number of identifiers from different systems, so an internal Epic identifier and equivalents in version 3 and MyChart and various other things. We have the person's name, phone number, address, marital status, who they're a patient of, etc. And it's warning us that some of the content is not necessarily valid against US Tor. And we can go take a look at that in the raw. So what does it look like in the headers? And what does it look like in JSON? And that shows us what the software system is actually receiving when accessing information about that particular patient. And one of the nice things that you'll see about FHIR is that it's not super hard to read. We haven't looked at the specification yet. You don't know the definitions of any of these things, but it's not terribly hard to understand what this data is. And that feature means that there's a pretty low learning curve for a brand new software developer who's being tasked to expose our data over this FHIR thing, for them to be able to look at the specification and look at examples and understand what the heck is going on. Another thing that you'll notice is that FHIR is a hierarchical exchange mechanism. So it's not like version 2 or SDTM or some of the other healthcare standards out there that are pretty flat and limit how much nesting can go on. FHIR lets you nest as deeply as you need to. We don't go crazy. We don't take you down 100 levels in order to get your data. We've had standards that kind of did that. But you can have multiple names, and each name can have parts, and the parts can have data information on them. And so it lets you nest as deeply as you need to in order to reflect sort of the internal complexity of the data. And let's see what happens if we mess around with stuff. So if I were to go into here and say, I'm not actually wanting to search by a specific patient identifier or a specific patient telecom, and try to run that, I think it's going to yell. No, actually, that still was enough for it. No, it did yell at me. So it's going to give me an operation outcome and say that, sorry, your particular search wasn't sufficient to narrow down to a single patient, and therefore you're not getting anything. And it's following good security practices and not telling you whether there are patients who match some of those characteristics or not. Because if you did that and you were smart, you could eventually narrow down some of the characteristics of a patient by asking the right searches. And so they just say, yeah, you didn't give us enough in order for us to resolve to a single patient, so we're not going to tell you whether that resolved to a whole bunch or resolved to none. Just try again and try to find more. We can also go and take a look at some of the other resources that do things a little bit more interesting. So if we hit back to the API list, and actually let me scroll up here, and let's say that we are interested in lab data. So that gives us a couple of different resources. And specifically, we're going to do a search for labs using release 4. You'll notice that observation can be used to search for a bunch of other things too. So you can use observation for smoking history, you can use it for vital signs, and that's not necessarily uncommon, where the same resource in FHIR is going to reflect multiple types of information in the underlying EHR. So they actually have different repositories or different tables in their database, depending on whether you're hitting vital signs or hitting lab information. And so here, if we try this out, we're just going to say, for this particular patient, find me all of their labs. And I can give that a shot. And this time, rather than a single result back, I've got 32. And I can scroll down and I can see all of these different lab results. So I've got a platelet count and when it was done and what the value was. And then I've got a hemoglobin and what the value for that was. And this is actually a somewhat unusual patient because a regular patient would probably have a heck of a lot more than just 32 entries in their lab results, but they try to make it not overwhelming in their sample interface. I could go up here and say, you know what, I don't want just lab results, I want vital signs, and do a search and retrieve that. Whoops, I spelled vital signs wrong. Have a space. Vital signs with a dash. I could go look at the specification, but I'm lazy. There we go. And so even though I'm taking a look at the lab part of the specification, this is talking to their live FHIR interface. And so if I make it go look at something else, it will go and retrieve that other content. And again, I can take a look at the same set of information in the JSON. And if I wanted to, I could hit this same link just using my browser to see what's actually going on here. So what is actually going on here? And to explain that, let's go back to the base FHIR specification. So h7.org/FHIR. And what we're using with Epic is the RESTful API. and that is shown here on the home page. There's a bunch of different ways of using FHIR to share data, but the RESTful API is the one that is most broadly implemented and also the one that is most interoperable. And the REST API gives us a way to do basic operations with FHIR. So create, read, update, delete. And there's variations on that. You can retrieve the history of a resource. You can look for changes to a particular resource over time. You can send a patch, which rather than sending a whole snapshot of the patient, you can just send the phone number or the address that's changed. You can retrieve what are the capabilities of a particular system. And this particular page, it's a fairly long one, goes through all of the details of everything that you can share. What does the different requests look like? What are the HTTP operators? And special things as well. You can do conditional creates. So only create this if you don't have somebody with that identifier already in the system. You can do updates that check for collisions. So do this update, but only if the current version is the version that I last looked at, all of that kind of stuff. And all of that is defined in that one page of the specification. So let's come back to the slide deck. REST is most commonly used primarily because it requires the least negotiation. The set of things that you can do are nailed down in the FHIR specification. You can do a create, you can do a read, you can do a search, you can do an update, you can do a delete. But there's only 12, 15 things total that you can do, and several of those are just variations of the same thing invoked at different parts of your system. And that means that it's pretty easy to get something up and running. And that's how the web works in general. When you want to stand up a new website, you don't have to get on the phone with Google or Microsoft or Apple to negotiate how their browsers are going to talk to your system. You use the HTTP spec and you use the HTML spec, and everything else just goes. And REST works the same way. FHIR defines the equivalent of HTML for healthcare. It defines the syntax of what the pages are, but HTTP defines what are the operations. The other benefit of REST is that it's pretty tight and lightweight. You don't have a whole lot of overhead. You've got all of the security infrastructure that you use for banking or connecting to Facebook or whatever. All of that is available to leverage, and it's cross-industry, so it's widely supported. It does, however, require that the client is in charge. The client decides what page you're going to go hit, what resource you're going to go query, and when. And it does require that the data have a fixed location. So you have to have a URL of the server that owns the data. If you're doing registries, if you're doing mobile solutions, if you're doing personal health records, et cetera, then REST is going to be pretty popular. And REST, in turn, serves as a foundation for other architectural solutions. So if you were at the executive presentation, you saw a little bit about this. We're going to talk about it again because it's important. There's a couple of solutions that are not part of FHIR but live on top of FHIR. One is Smart. And what Smart does is it lets you run apps inside of an EHR or against the data held within an EHR. It does the same kind of thing that apps do on your phone. So rather than buying a phone and the only thing that you can run there is the content that was shipped on your device, you bring your phone home and you go to the App Store and you download all of the custom applications that do the things that you need, whether it's movies or books or chat or whatever. You will customize your device to do what it is that you want to have happen. And Smart does the same thing, but within an EHR. And just like your phone apps will say, I'd like to use your microphone, I'd like access to your contacts, your Smart application will say, I would like access to the patient demographics and to the patient allergies. and maybe just for search or maybe for search and create. And once you provide that access, that app can extend the capabilities of your system and customize the capabilities of your system. And we'll take a look at some smart apps later on, either today or tomorrow, to see what those do. In addition to that, we have CDS hooks. And while Smart on FHIR is about providing a user interface to let a user manipulate data or see data in a particular way, CDS hooks is about providing decision support. So quite often in healthcare, there are external systems that can provide some guidance and some useful information as a clinician or administrative staff are going about their daily work. So a patient first comes into the clinic, or you're booking an appointment or a referral, or you're ordering drugs or a lab test or something like that. When you do those things, there may be information that can be provided by a research system. So the patient that you are booking an appointment for is actually scheduled in for one of their clinical trial visits 3 days later. Maybe you want to shift the appointment date and have them come in once rather than twice. Or that drug that you're prescribing is not covered by the patient's plan, but this one is, or it is covered, but you need a prior authorization. Would you like to see the questionnaire you need to fill out in order to get authorization for that drug? Or this X-ray that you're ordering of their left arm, are you aware that there was an X-ray done of their left arm 3 days ago, and maybe you want to go use that one instead rather than ordering a brand new one? And so CDS hooks allows systems to tie into the EHR and provide guidance in a fairly unobtrusive way as the person is going about their daily work. Both of these solutions rely on the FHIR RESTful interface in order to get data. So the Smart app, the data that it's displaying, or the data that it's allowing users to edit and create, that works because the EHR has a RESTful interface that lets you create and update and search the data. And similarly, CDS hooks, when you are trying to decide, is this medication covered or not, you may need to go and hit the patient demographics or go and grab the patient's coverage to make a determination of whether that medication is covered. And so you need to have a standardized interface that you don't have to negotiate. That's the key thing here, is that REST gives us a interface that you don't have to have every single app go and talk to Cerner and Allscripts and Epic and everybody else to say, this is how I would like to share data for this particular use case. The generic mechanism that FHIR provides lets you do all sorts of different use cases, many of which were not even conceived at the time that Epic and Cerner and Allscripts stood up their solutions. They just say, here's the data, go and access it as you see fit, much as phones may go and access your contacts and do all sorts of cool things with them that were not necessarily envisioned at the time that Apple and Google defined the interfaces to access those things. Any questions about anything that we have seen so far? If not, we're going to jump back and go take a look at some additional parts of FHIR, specifically how do you navigate the FHIR spec. So the FHIR homepage shows a set of modules. Well, actually, before you get to the set of modules, there's a first time here area. And if this is indeed your first time here, not right now perhaps, but sometime soon, I'd encourage you to browse through those because there's a bunch of guidance there that will help sort of provide some context of what the heck FHIR is and how it works, and how to read the spec. That's also helpful, and how to navigate the spec. But the guts of the FHIR specification are a set of modules. So we've got some foundational stuff that doesn't matter what kind of solution you're building, you're going to need to understand these things. So how do you do FHIR as XML or JSON? What are all the data types? What is this extensibility thing? And then there's a number of sort of infrastructure modules. So implementer support, that's the first thing listed because implementers are the most important people to us in FHIR. but there's information on security, there's information on conformance, terminology, and then building on all of those, how do you actually share healthcare information? And then beneath that, we get into the different types of data. So administrative, so who are your patients, who are your care team, who's your practitioners, that kind of thing. And then all of the different healthcare disciplines. So clinical gives us allergies and problems in care plans. Diagnostics is the imaging stuff and the lab stuff and the vital signs. Medications, workflow, so how do you ask for something to be done? How do you say, please fulfill this lab test, or please cancel that order? A whole bunch of stuff around claims and reimbursement and eligibility. And then sitting on top of all of those is the healthcare reasoning content. So how do you actually define new decision support? How do you define quality measures and that sort of thing? And then there's a bit of support stuff down here at the bottom. But we're going to go and take a look at resources, because resources are sort of the most important thing in FHIR. That's how we organize all of the data that you might want to share. And there's a bunch of them. This is the full list of resources. So just click on that little resource button at the top. And there's infrastructure resources, so resources that actually define the FHIR specification itself. There's a resource for every resource. So there's a structured definition for patient, and a structured definition for observation, a structured definition for allergy, and a structured definition for the codable concept data type and for the human name data type and all of that kind of stuff. And then we get into the more interesting resources. What do you need in order to actually share data? So we're going to go take a look at this patient one. That little green thing says, hey, I'm normative, which means that patient is one of the resources that is now completely locked down. We promise to remain backward compatible with it forevermore. We're currently working on taking a whole bunch more resources normative as part of release 5. So this is the layout that you will see whenever you come into a resource. So who owns this? If I don't like what it looks like, who do I go beat on or engage with to get the content changed? How mature is it? Some other general stuff. You can ignore most of this. But a description of what the heck is a patient. And patient is pretty broad. So it covers not just inpatients, but outpatients. It covers animals. It covers social services. It covers the human being who is wearing a Fitbit that you're capturing data about. Even if they've never seen a physician in their life, you're still capturing healthcare related information for them, and they are a potential recipient of care, and therefore they are considered a patient from HL7's perspective. Then we see the data structure for patient. So patients can have identifiers. There's a flag that says whether their record is active or not. They can have a bunch of names. And human name doesn't mean that it is a name for humans. It means it's a name assigned by humans. So Fluffy, the cat, is a human name because the official name for the cat is something that we probably can't pronounce, and we don't generally capture in the electronic breath record. Patients can have contacts. So what is their phone number? What is their email address? Maybe what is their website, if that's a thing. What is their administrative gender? So there's a section down below in the notes that talks about all of the joy that is gender in terms of various types of genders that patients can have, of phenotypic and genomic and social and all of that kind of fun stuff. This isn't trying to do any of those things, and therefore it's a fairly limited code set, and you can go and see what that code set is. You can have a birth date. You can have either a flag that says that they are deceased or a specific time that they're deceased, but you can't have both, because if you indicate a deceased time, then the flag is sort of implicit, and we don't allow you to send both, because as soon as you allow people to send both, then somebody sends a flag that says the patient is not deceased, deceased boolean is false, and their deceased time was 1988, and then you have conflicting data, and that's not fun, so we just don't let you send conflicting data. You can have addresses, you can have contact information about their mother or their children or their great aunt or their neighbor or other people, sort of next of kin type information. What languages do they speak? Who is their general practitioner or set of practitioners? what organization owns this patient record, and links to other patient records that are tied to this one. And if you don't like that view, there's a pretty picture view. So people who prefer pictures, you can see things that way. And all of the same information is available. So you can hover over identifier and you can see that short descriptive label. If you want to look at the way that the JSON looks, this organizes that same definition, but in a way that is reflective of what a JSON instance would actually look like. And you can take this and copy it into your editor and start filling it out and have a valid patient instance. There's also XML and RDF. We won't worry about those. If you care about how his patient changed since our previous release, so what did the patient look like in R3 and how is R4 different? There's formal mappings there, and there's actually executable mappings you can go download. And if you hate trees and want to print out all of these things, then there's a tab for that too. And if we scroll down further, we have a list of all of the terminologies that are used, some constraints. So there's a rule in patient contact that says you need to have at least one of name or telecom or address or organization. And so that's not something that we can just enforce with cardinality. That's something a little bit different. And we explain that. There's explanation around identifiers. There's explanation around linking patients. There's that promise section on the joy of gender. How do you link moms to their children? How do you deal with merging? How do you deal with master patient index? How do you deal with veterinary? And how do you search for patients? So lots of information around patient. You can see here cardinality. So identifiers are allowed to repeat, whereas the active flag is not. If you wanted to, you can go dig into a data type and go see what the identifier scheme looks like. It's a big page. It's got to load the whole thing first. And there we go. So identifiers have a use. So what kind of identifier is this? Is it an official identifier, a temporary identifier, that kind of thing. There's also a type, which provides more fine-grained and variable information about the identifier. This use code is fixed. Everybody in the world uses that. Types, on the other hand, you can go and invent your own. There's the system, which defines the namespace for the identifier. We're going to talk more about that in a little bit. There's the value of the identifier. So I am patient 123 within this particular namespace. There's the period that the identifier is valid for, and there's who assigned it. And that's the information that you can capture. And again, there's multiple views on that. If you scroll up to the top here, you can see a list of all of the data types and how they relate to each other. If we go back to patient, you'll also see that patient is part of a hierarchy. And there's a quick list here of all of the things that patient inherits from above. But if we follow that hierarchy, we can see that patient is a domain resource, which means that it can have narrative, which is a human readable view of the resource, and can contain other resources inside it. We'll talk about that later too. And it can have extensions and modifier extensions, and we'll talk about those. And then a domain resource is a type of resource, and resources have identifiers and they have metadata, and they have this implicit rules thing, which is a get out of jail free and do whatever the heck you want flag that we put in there for safety, so that when people are doing breaking things, that they can flag the fact that they're doing breaking things, and people can say, yeah, this is dangerous. I don't want to touch your instance because you're doing weird stuff. And there's what language is the resource expressed in. So lots of content there. And in addition to those, back up at the top, we also had a number of tabs. So if you want to look at examples of patients, you can go and take a look at a whole whack of sample patients. What do they look like in the specification? Because we know that real developers don't actually read the spec, they just go find an example and code from that. Not completely true, but more true than we might want it to be. There's also detailed descriptions. And actually, if we were to go to the content tab and we were to click on any of these hyperlinks, that jumps us to that detailed data dictionary page, so you can go see formal definitions, you can see usage notes. So this explains the fact that human name is the name that is assigned by humans. So Fluffy the cat or Betsy the cow. We have mappings to a bunch of HL7 specifications and to other things too. So if you encounter version 2 or CDA, there's guidance for that. There's profiles and extensions. So these are elements that were not common enough to meet, to get included in core, but they're common enough that we figured it's worth defining a standard way to convey them. So the patient's religion or the specific time that they were born, as opposed to just the date, or nationality, your mother's maiden name, that kind of stuff. There's operations. So if you want to do an MPI, master patient index lookup, or you want to retrieve all of the data that's associated with the patient record, all of that is there. And then we have the formal executable mappings between release 3 and release 4. So lots and lots of support in the FHIR specification. And so the first thing that you're going to be doing when you're going to FHIR is, first of all, trying to figure out what resource am I wanting to map my data to. So you go take a look at all this list of resources and say, which of these looks like the thing that I'm looking for? Sometimes that won't be obvious. And so instead, you're going to say, what I'm interested in is where do I send a genetic variant, and that pops up an ad. Yay, Google. Well, actually, this is DuckDuckGo. Yay, everybody who does search. But this is within the FHIR specification, the guidance on how do you do genomic stuff. And so you can come here, and this actually says, hey, there's actually a formal genomics implementation guide you might want to go take a look at. So you will often start with that process, and you'll go read the introduction to the resource. So if we were looking at observation, we would go in and see what is the scope of observation, what kind of stuff fits in there and what doesn't, and make an evaluation of whether that was right or not. But sometimes that's not going to be sufficient. It's not going to give us a, there's two or three possibilities, or we can't find what we're looking for. And so we have a question. And when you have questions, if you go back to that home page and go down to the very bottom, there's a community forum, which is okay, but chat is much better because there's a whole lot more people on it and you'll get an answer much quicker. And so if you go to chat.phir.org, when you first sign up, you will not see all of these. I monitor a whole lot of stuff, but if you click on that tiny little almost invisible gear icon, you will see all of the streams that exist, and you can sign up for the streams that you're interested in. You'll automatically get announcements and implementers in social, but the rest of them are specific to different areas. So there is, if you are interested, for example, in research, there is a specific stream for research and another one for biopharma. Or if you're interested in care plans, let me just take plan instead, because care is a pretty common word. There is a stream for care coordination. And so you sign up for the streams that you're interested in. As of yesterday, there is a brand new stream for Israel. So all of you should go sign up to that, because that is where you will be talking about the specific considerations around using FHIR in Israel. Are there particular types of identifiers that you need to worry about, or particular social conventions that you need to worry about? They're going to cause you to use FHIR in a specific way, or cool conferences that are coming up, etc. But most of the time, you will simply come to this implementer stream and post a question. And I last looked at this stream at around midnight my time yesterday, and there's already 27 new posts. I was looking at Yoel's snapshot when he was showing off chat.fhir.org, and he's further behind than I am. It's okay. You don't have to keep up. I'm one of the very few people who actually tries to keep up on all my streams. Most people just come in and search when they care to. But you can, first of all, come here and search to see if anybody has discussed your question previously. You just come up here and do a search. But if you don't, then you can come and add a new question. And there is somebody online somewhere in the world who probably has an answer and will get back to you in minutes or hours. Even on major holidays, somebody somewhere doesn't have a life and will give you an answer. And sometimes there will be discussion because it's not a clear answer and there's multiple things to consider. And you might not walk away with an answer. You might walk away with an instruction of, you know what, that's a really good idea. Please submit a change request. So let's go back to FHIR specification. And I'll show you how to do a change request. At the bottom of every single page in both the core specification and all of our implementation guides is a little propose a change link. And the first time that you come to this, you won't actually get here. You'll get to a screen that lets you register for an account. It's not automatic. There's a skill testing question, which is, why would you like to have an account? And if you are a Viagra salesperson, your answer is going to be pretty obvious to us that you have no idea what tech FHIR is or what healthcare is, and we won't give you one. But if you provide anything that shows a vague understanding of what HL7 is and what FHIR is, then we will give you an account. And once you've got one, you can come in and submit new change requests. And we have 15,000 change requests or so logged. Actually, probably more than that, probably closer to 20,000. We're at 29 because of stuff. But you can submit change requests against any specification, whether that's you found a typo that needs to be fixed, or there's a problem with the schema, or you'd like there to be a new data element added, or the description isn't clear, or you're looking for guidance on a particular problem and that you think actually should make it into the specification. You can create those, and that flows into the JIRA queue of the appropriate work group, and they will review it. They might not review it right away. Some work groups are 2 or 3 or 4 months behind, but they will get to it eventually, and your change request will be hopefully addressed in the next release of the FHIR specification. In addition to that, there is one other source of support, and that is our Confluence site. Well, actually, you can go take a look at the blog, because there's a bunch of useful content there too. But if you go look at Confluence, this is all of our internal stuff. So if you are interested in looking at minutes of the group that manages FHIR, or you're interested in some of our guidance for designers, people who are creating implementation guides, how to use the IG publisher, how to use the validator. On the implementers tab, there's cheat sheets. So if you want to go and grab a nice little cheat sheet that you can print out for your desk and keep beside you as you are, man, that's not my internet, I don't think. I think it's HL7's. Needs coffee this morning. Oh, it's not morning for you. Coffee in the evening's okay as well. But there is a handy dandy little cheat sheet and lots of other resources that may be useful for you in exploring FHIR specification. And it's put out by an organization that holds a conference, so they get to advertise, but that is everything that you wanted to know about FHIR on one page. So feel free to download that and also browse around to see what are the other kinds of resources that are available on that Confluence site. All right, let's go back and take a look at Epic again. So they logged me out because they're secure like that. I'm going to log back in. And I want to go back and look at patient. We're going to try it again because I want to look at something specific. And the specific thing that I want to look at is this. Patient has extensions, and there's an extension here for race, and there's an extension here for ethnicity, and there's an extension here for birth sex. And extensions are an essential part of FHIR. The fact that you could look at that patient resource and it pretty much fit on a single page, certainly 8.5 by 11, you can print it out and read it and understand all of the data elements that are on that resource. The only way that we get away with that is because we don't try to include every concept that exists everywhere in the world. Because if we did that, there would be 300 or 400 or 500 data elements on patient instead of 20-ish. And so built into FHIR is an extension mechanism where every resource and every element in a resource, even birth date, can have extensions. Because maybe instead of capturing an actual birth date, you want to capture a text string that said that they were born under the full moon in the summer of 1950, because that's what you've got from the patient. Or maybe rather than conveying a birth date, you're going to convey an extension that is their age at the time that the study started, because that's how you capture data. Or maybe you have a Boolean, but rather than just capturing true or false, you want to capture the original text that the human being saw, because that's important in a research context. So extensions can exist pretty much anywhere. And they are the safety valve that allows us to say, you know what, that requirement that you have, that's not something that is broadly supported by most systems throughout the world. So race and ethnicity, there was a lot of arguing about those in terms of whether they should be part of the core spec or handled as extensions. But when we dug into it, what we found is that race and ethnicity are almost always captured on patient, at least, in the demographic structure for social political reasons. They are not really clinical things. They are reporting things. And in lots of countries, it's not only not done to capture them, but it's illegal to capture that kind of information. But where it is done, the information that you're capturing tends to be quite different, and it's based on the cultural history of that particular country. So the US codes for race and ethnicity, forget which one. One of them is essentially, what kind of Hispanic are you? Because that's really important to them. If we were going to do that same sort of thing in Canada, we'd be much more interested in what kind of First Nation status do you have? And we've actually defined an extension in Canada to do exactly that. But neither of those things are necessarily going to be as relevant to you in Israel or as relevant in Japan or elsewhere. And so they are defined as extensions. If you wanted to capture somebody's actual racial ethnicity from a genetic perspective, you wouldn't be capturing that on patient in terms of their demographics. You would be capturing that as an observation, and you would be providing what is your evidence for making the assertion that somebody has a particular genetic heritage that could be relevant for care. When we get to extensions, there's a whole bunch of questions that we need to think about. And I'm going to go back to the slide deck so I can figure out where my cursor went. There we go. The first thing is, what do you do if you receive an instance that contains extensions and you don't recognize them? Because the reality is you probably will. People will send extensions for various purposes that are not necessarily things that you recognize. And actually, I'm going to very quickly jump back to Epic, because when you look at an extension, you see that it has two pieces. It has a URL and it has a value. The fact that it has that URL, actually, I'm going to collapse this so that you can see that better. The fact that it has this URL means that any extension that you encounter should be discoverable. If you're familiar with certain other standards that have extensions, version 2, version 3, others, there is no way to have any clue what an extension means without talking to somebody on the phone or reading a PDF somewhere that explains it, provided that it's documented at all. With FHIR, there's an expectation that there is a formal computable definition for the extension and that you can get at it. You don't have to have this URL be resolvable, but if it's not, you are required to ensure that the definition of the extension is available to everybody who receives an instance that contains it. So you should have a situation where you're receiving extensions where you can't find out what they mean. But that's more for humans than for software, because if you just receive this URL, yes, I can go download the structure definition, but that still doesn't tell me what that means in terms of my software. And so what do I do in that circumstance? And the answer is you can safely ignore them, because extensions are never going to change the meaning of anything. If I receive this patient and I say, I have no idea what US core race and US core ethnicity and US core birth sex mean, I don't know how to store those things, I don't know what they're for, that's okay. You can toss them, you don't have to store them, and that's still a safe thing to do. We're going to talk about why it's safe in a second. And it's actually good practice to toss them. It is not good practice to say, hey, there's an extension in your instance that I don't recognize, so I'm going to reject your instance. Because when you do that, what you're saying is, I need you to customize your interface to strip out data and maintain that custom interface for my system forevermore. And that's going to cost you money when I could ignore that extension for free. And making other people spend money forever when you can ignore something for free is generally pretty impolite. There are some systems where if they allow data past their front door, they are considered to have legal responsibility for it and they can't ignore it. And so those systems might choose to not allow the data past their front door if they don't recognize it. But in most circumstances, it's fine to ignore that, and best practice to ignore it. Sometimes you'll receive data that contains extensions you don't recognize, and you could throw it away. But if you throw it away, then the people who sent you the data will be sad because they'll come back tomorrow and they'll try to query for the data and it won't be there anymore. So it's kind of nice if you can store it. And there are some ways that you can have sort of generic structures in your system that know how to capture arbitrary stuff. Even if you've got a legacy data store, you might have a place where you can capture annotations or some sort of a generic mechanism to store extra stuff. And you can possibly tie extensions into that and store them. You don't have to, but you can. If you're going to store extensions, do keep track of where they were, because they can appear at different places in your instance, and also keep track of whether people are changing the data. If I have an extension inside patient birth date and somebody changes the patient's phone number, that's fine. I can continue to hold on to my extension. But if they come along and update the patient's birth date, then that extension that's sitting inside birth date is probably suspect. And I might want to consider whether I need to throw it away, or at least give the human a chance to figure out whether perhaps it should be thrown away. Also, because extensions are things that you can resolve and look up, you can have a dynamic user interface where you add in these data elements you have no idea what they mean, but you can look them up and you can figure out what is the value set that's allowed for this, or what is the data type that it has, and what is the common display name for it, and incorporate that into your user interface on the fly. We don't have a whole lot of systems that do that right now because it's kind of hard to create dynamic user interfaces, but there are some that do, and that's available. In terms of your own stuff, when you're mapping your local data store to FHIR, the first thing you're going to do is try to figure out, can I map this stuff into a standard element in one of the resources? And most of your stuff will probably have a home there. Sometimes it won't, and then you'll look at the standard extensions that are defined by HL7 or defined by Israel Ministry of Health or whatever organization you set up to manage sort of national level extensions that everybody in Israel uses. Or you might also look at implementation guides for genetics or registries or other things that are international in scope and use those. But sometimes you won't find your data element there either. The next thing that you do is you go ask a question on chat.phir.org and say, this is the kind of concept I'm trying to represent. Here's some examples. Here's how I use it. Is there a place for that? And you might very well get an answer back that, yeah, actually stick that in this core element, and you didn't recognize it because it has a name that's not the name that you use internally or you use in your particular area of healthcare. And maybe we'll suggest that you submit a change request for us to add an alias so it'll be easier for us, new people to find in the future. Or maybe we'll say, actually, you don't generally capture patient's hair color or patient's eye color as attributes on the patient resource. Those are observations. And here's LOINC codes that you can use to capture hair color and eye color. But sometimes we'll say, you know what, yeah, there's nothing for that. Go ahead and create an extension, and then you will do that. And when you create your own extension, tuck it inside whatever element it's most related to. So if it's an extension related to patient contacts, stick it inside patient contact or stick it inside patient birth date or whatever. But sometimes you'll need to stick it on the root, and that's fine. And then put it in a registry so that people will be able to find it. And if you do that, then you have the ability to capture any kind of information you want. There's never a situation where you can say, well, I want to share this information in FHIR, but FHIR doesn't support it, because FHIR can support any kind of data you can imagine. Extensions will allow you to send anything, including complex structures. You can have extensions that are themselves made up of extensions. So you can have pretty complex structures that way. Want to go back now to EPIC. Because below extensions, they had identifiers. And actually, they have a couple of different types of identifiers. We have this resource ID here, which is this string that you probably don't want to quote to anybody over the phone or try to type into a form, because that would be evil. But you also have a bunch of identifiers that look like this. And that's going to be much easier to read over the phone and to communicate to people on a form or something like that. The resource.id, think of it as the primary key. This is the identifier for this particular patient as it is stored on this server. If I copy this patient record to a different server, I'm going to expect this ID will usually change. Just as when you copy a record from one database to another database, the primary key is usually going to change. It doesn't have to. You can have synchronized systems where the keys are shared and where the keys propagate for various architectural reasons. But most of the time, the IDs, the keys are going to vary from system to system. And that means that I can't arbitrarily go to some FHIR server out there and say, well, I know what the key is for Lloyd McKenzie, and go look myself up using my resource ID, because I have no idea what key they're going to use in their database for me. However, we also have identifiers. And identifiers are sort of the business level identifiers, and they can be things like, in the US, a social security number, or in Canada, a social services number, or they could be a military registration, or they could be a beneficiary number under a healthcare plan, or they can be the medical record number in a given EHR. And those identifiers are expected to be globally unique by taking two things: the system, which is some sort of a URI, ideally a URL, but it doesn't have to be. So this one is a URN OID. It could also be a URN UUID, or it can be a resolvable URL, which would ideally go to a place that explains what type of identifier this is. And then there is the value, which is what you would typically show on the screen. So you might have XYZ system that corresponds to XYZ hospital medical record number, and then you have E2731, which is the specific identifier within that system that together give you a globally unique ID. System isn't mandatory, so if you receive a random piece of paper somewhere that has a record identifier on it, but that record doesn't actually tell you who the patient is or what the system is, you can still put that into your record and just say, this is an identifier. I have no idea what the system is. I can't uniquely resolve it, but it's something I can at least try to search on. That's possible. If we go into the FHIR specification, let's go to patient. You will see that both of those things are defined here. So ID is inherited from resource, and identifier is defined here directly. And the typical pattern is that most resources will have an identifier and will support many of them. These are the things that you expect to remain constant across servers. So the patient's medical record number will be present in the admitting system and in the pharmacy system and in the lab system and in the claims system, presuming that you got a copy of the patient record in all of those. Sometimes you'll just have a master patient index and everybody will just point to that. That's fine too. If you've got a military ID record, then that will even span multiple organizations. So, or if you've got a national citizen identifier, that kind of thing. All of that's available. One of the challenges is how do you figure out what system to use? Because if I'm capturing military ID and you're capturing military ID, it would be kind of helpful if the systems were the same. So I'm going to jump to something that Canada has set up, which is our URI registry. And so within that, we've got a whole whack of naming systems for all of the different types of identifiers that we use in Canada. So the Ontario Dental Surgeon License Number, or the Canada Correction Services Health Card Number, or the British Columbia Facility Code, or Alberta Health Service Provider Identifier, Canada Social Insurance Number, Veteran Affairs Number. And these are defined in a standard registry that everybody in the country has access to. Everybody in the world has access to, actually. Not that most people are going to care. And if we go take a look at this, so if you want social insurance number, this is the system value that we use. Actually, no, this is the system for the naming system, but this is the system value that we use as a URI for identifying social insurance number in Canada. And any system can look that up. There's a computable interface where you can go query those. And so somebody can do a search for Alberta and find all of the Alberta related identifiers and say, okay, this is the one that I want, and therefore ensure that everybody is using a consistent identifier. You don't necessarily have to stand up a registry. You could just have a PDF sitting somewhere, but you will probably in Israel have common identifiers that are not specific to a particular organization that you want to share. And so there is a resource for doing that, and also for mapping between identifiers used in systems like CDA versus ones that are used in FHIR. I haven't had any questions yet. So either you have none or you didn't have enough coffee before a late afternoon presentation. So do feel free to go and grab coffee as you need it and when you need it, and also do feel free to ask questions. I'm going to come back to the presentation. And we're going to talk about a special type of extension, and that's modifier extensions. Remember that I told you that extensions are always safe to ignore. And the reason that extensions are always safe to ignore is because we have a special extension with a different name called modifier extension. And you didn't see any of those in the EPIC system. I'm not sure that they support any, to be honest. But modifier extensions are extensions that change the meaning of stuff. So imagine that you have a procedure resource and you want to be able to say, actually, this procedure did not happen. So patient did not have an appendectomy. You don't want to ignore an extension that says that. That would be bad because you've got a patient who's got dementia and they're complaining of abdominal pain, and you talk to them and they say that they had their appendix out when they were 6. And if you ignore the modifier extension that's in their record, you will see that they have a record of an appendectomy. And so you will exclude that as a consideration as you're trying to diagnose what's going on. But in fact, their appendix is fully intact. There's an MRI that shows that their appendix is fully intact when they were looking for something else. And they're just confused and you can't explain it to them because they've got dementia and they won't believe you anyhow. So for those kind of extensions, we use the modifier extension element. And that basically says to everybody, don't ignore this if you don't recognize it, because it changes the meaning of the resource as a whole or certain other information in the resource. Maybe you've got an extension on patient contact that says, do not contact this person. Maybe you're providing your mother's name as next of kin, but you really don't want her knowing that you're in the hospital. And you don't want that do not contact to be ignored on a list of patient contacts. And so if you can't ignore it, what can you do with it? And there's a few things. One is you could reject the instance, say, sorry, you're sending me a claim, it's got a modifier element on it, I don't know how to handle that, and I don't let humans look at my claims, I do all my claim processing real time, I can't process this, so go change your data. Or you could say, you know what, I don't know how to process computably, but I can throw it into an exception queue for a human being to look at. Or maybe you'll say, you know what, patient contact is not something that matters to me. I don't actually pay attention to patient contacts at all. So the fact there's a modifier extension on them, I don't care. I'm not gonna, I'll just throw this entire contact away. I don't need to store contacts generally, so I'll just toss this one because it's not safe because I don't know how to store that particular modifier and I don't want to propagate it to somebody else who might care. So I'll just toss that whole contact. All of those things are valid. In terms of when to use them, don't use them if you don't have to. If there's a better way of sharing the data, maybe capturing an observation instead of a extension on the element, that might be better. But if you really need the record to show up in the list of procedures, because you don't expect people to look anywhere else, and modifier extension is the only way to say what you need to say, then use it. That's what it's there for, and we would much rather you use a modifier extension for something that is a modifier than cheat and use a regular extension and have people throw it away and have bad things happen as a result. By the way, you don't actually need to use a modifier on procedure anymore, because as of release 4, there is a standard element on procedure that allows you to say this procedure did not happen. And actually, let's go take a look at that, because that ties into something else. So if we go bring up, I'm not going to bother jumping up to the list of resources anymore because I know the names of all of them because I've been doing this for a long time. So I'm just going to shortcut to get us there faster. But if we go look on procedure, this little element has a question mark exclamation mark on it, which is our symbol that says this is a modifier. This element can change the meaning of the instance, so please don't ignore me. And if we go look at the list of elements here, it includes procedure was not done or procedure was entered in error. And obviously, if you're looking for a list of patient surgeries, you don't want to ignore the entered in error or the not done things because obviously those are procedures that the patient didn't actually have. So some resources will have lots of those, some of them not very many. If we go back to patients, there's a couple there as well. The active flag is a modifier because this is no longer an active patient record, kind of suggests that they're not a patient anymore, or patient deceased, they're dead. For most types of care, that also means that they're not really a patient anymore, although that's not necessarily true for everybody. Somebody is drawing on my screen. That's cool. I don't think it was me. Maybe it was me. But that's modifier elements. Any questions about anything that we've covered so far? So modifiers or extensions or identifiers or references or any of that stuff? You will need to come off mute if you want to.
Maybe one question.
Go for it.
If I have like a service that accesses the FHIR server and patient has several IDs used, how can I define which ID am I looking for or get no errors reading, let's say one health provider looks for a typical ID and one other will to look at a different ID. Is there a way to define which ID I'm looking for?
Sure. So you're wanting to ensure that multiple servers support the same identifier so that you can match across them? Is that sort of the question?
Say again, sorry?
You're wanting to set some rules so that multiple systems are going to use the same identifier so that you can search for patients across them. Is that the question?
I talked about the other way around. Different systems will use different identifiers for the same patient. How should we look for the right ID?
So you have that system and that value. So each identifier that a system assigns is going to have a distinct system. So you might have one that is a URL that says hospital XYZ medical record number, another one that says payer ABC member number, another one that says clinic 123 patient identifier. And so that system is going to be different for every different identifier. So even if all of them have patient 1 or patient 5, because the system URL is going to be different, that means that you won't get a match so long as you are searching by both system and value. If you search only on value, so you say, find me all patients with identifier value 5, you will potentially get some patients who have the wrong, who are the wrong patient because the identifier system wasn't specified, and there are multiple patient 5s with different types of identifier schemes. So that's not as safe, and you may have business rules that don't allow you to search without the system, but in some cases, you have identifiers and you don't necessarily know the system, and if you've got an identifier value and you've also got a name and you've also got a gender, then perhaps that combination together is sufficient to exclude the wrong one, and you'll still be able to find them even if you don't know the identifier system. Did that answer your question?
Yeah, thanks.
No problem. Thank you for asking the first one.
Lloyd, we're having a question in the chat. If you from Izar, I think it's a question if you can see it.
Yep, I can, and it's an awesome question because it's exactly what we're about to get into with the next 4 or 5 slides. So I'm just going to go through the slides and then I'll check back and see whether that's a sufficient answer for you. But awesome segue. So let's take a look at what the components are for a server. And here we're focused specific on REST. So at the front end, you're going to have some sort of an HTTP or REST interface, and there's nothing FHIR specific about this. This is the software that knows how to do TLS, establish a secure connection, understands how to parse and escape and unescape your search parameters, knows how to do redirects, all of that kind of fun stuff. And you can find libraries off the shelf for pretty much any language that exists that knows how to do this stuff because everybody uses the web these days. Behind that, you're going to have a FHIR service. And you can choose to have your FHIR service handle all that front stuff too if you want to write it yourself, but probably you'll use the library. The FHIR service is the piece that understands the FHIR specific rules. So it understands that if your URL includes /patient, that you're talking about the patient resource, and that's the part of your database you need to talk to. And the question mark identifier equals is referring to a particular type of search parameter and how to search that kind of thing. And that is going to be FHIR specific. And that FHIR service is going to talk to your persistence layer. And maybe your persistence layer is FHIR centric, but quite often it'll be a legacy persistence layer that is used for other purposes as well. And your FHIR service will map to and from that storage mechanism, however that behaves. Quite often, your FHIR service will also talk to an additional repository, which is an index repository that is specifically tuned for FHIR. And the reason for that is that when you search using FHIR REST, it's not as though you were searching using SQL or something like that, SQL, where you can search any data element and you can search any way you like. With a FHIR server, there are specifically identified search parameters that behave in a particular way. So for example, there is a name search parameter on patient, and that name parameter says that it is by default a starts with search, it is case insensitive, and it is accent insensitive. And you could do a transformation on your data as you are searching to make it case insensitive and accent insensitive, but that's pretty expensive. And so having an index that already does that whenever you create or update the patient's name to store a case insensitive and accent insensitive representation of it for more efficient search is something that you will often do. And you only need to index those search parameters that you support. So if you support searching on name and gender and identifier and date of birth and nothing else, you don't have to have indexes on patient contact phone number or deceased date or all of the other information that exists in the patient record. And so what that looks like is inbound, you have JSON or XML or possibly RDF, and you will generally parse those into some sort of internal object model, so plain old C objects or plain old Java objects. You don't have to if you really want to manipulate the JSON directly or manipulate the XML DOM directly, you can, but there's lots of reasons why turning it into an object is going to make sense. And then once you've done that, you're going to want to store the data. And there's 3 different strategies that we see used with FHIR. One is a traditional object relational map. You use a tool like Hibernate and say this particular class, this particular property maps to this table, this column. And you define your maps for all of the properties in your objects, and they all have a home somewhere or other in your database system. And there's trade-offs that you make there. So address is a complex data structure because it can have multiple lines, and you can have a country and a postal code and all of that kind of stuff. And for some systems, you're going to want to break those out into separate columns in your database because you want to be able to search by postal code or city or address line and know those are distinct things. For others, you don't search by address at all, and it may be fine to just store that as a blob. Or maybe you store a blob and then break out a couple of pieces. So you can search by postal code and you can search by city, but the rest of it is just handled as a blob, and you'll make decisions like that as you're breaking things down. Second possibility is that you'll store it in some sort of a NoSQL repository. So something like CouchDB or equivalent system, and you'll store either XML or JSON or possibly RDF in a triple store, and you will leverage XML query or some sort of a JSON query mechanism to access the data and access the specific elements. The third possibility is that you'll use a relational database, but rather than breaking everything apart using a map, you will just store a blob. So here is my patient stored as JSON. Here is my provider stored as JSON. And you can get away with that because when you are returning data from a FHIR repository, you are always returning a full-blown, or almost always returning a full-blown resource instance. So you don't have a search that says, just give me the patient's gender and date of birth. You're going to return a full patient instance. You can choose to filter that and strip out certain elements if you want, but the base resource that's coming back is always the full thing. And so if you've got a separate index repository that lets you figure out which resources are included, you don't necessarily need to partition your data into a whole bunch of tables and a whole bunch of columns to make that work. However, that approach only works if you're only using your data for FHIR sharing purposes. It's not going to work if you are have a legacy relational store, obviously, or if you're wanting to do analytics or other kinds of things that require access to the individual data elements. In terms of persistence, if we go into the FHIR specification and go back to the home page, oops, select my window before I go back to the home page. In that implementer section, the first thing that is there is for downloads. And if you scroll down to the bottom, there's a bunch of reference implementations. So Java, C#, Pascal, Swift if you're doing Apple stuff. And each of these are existing libraries that know how to parse and serialize and store FHIR data. And if you go and dig into, for example, Happy, and go into their documentation and go take a look at their parsing and serializing. Actually, no, it's not parsing and serializing. Where's their persistence layer? There we go. Talks about how Happy works. And basically, Happy can talk to any kind of a database that Java can talk to. So you can plug in Oracle, you can plug in DB2, you can plug in any kind of a database that you like there. In addition to that, in Happy, and I'm rather than wandering around searching for it, I'm just going to jump us directly there. They also have let me just bring that up so that I can click on the link and it will actually launch. A mapping layer that allows you to map to arbitrary data persistence layers. The same thing exists for .NET. So they have a facade mechanism that allows you to basically build a FHIR interface on top of an existing legacy system. And so you don't actually have to talk directly to the persistence layer. You can talk to other APIs to do that. There is also on chat.fhir.org a whole stream that talks about different storage mechanisms and persistence approaches and strategies. So all of that is available to you as well. And then finally, there are tons of interface engines out there and larger sets of infrastructure that know how to map to and from FHIR and give you tools for doing all of that. So there are lots of different strategies for taking your existing healthcare system and building FHIR interfaces on top of that. You don't need to write all of that stuff from scratch. You can use existing libraries to make that work. So did that sort of cover off what you were looking for in terms of mapping process?
You're muted, so if you want to say yes, then nodding is not enough. Lloyd, there's another question on the chat, a follow-up question to my question from before.
Yep. So the next one is there a super identifier solution? And there can be. So it depends on the country. FHIR is not going to impose a super identifier solution. In Canada, all of our healthcare is provincially driven. So we have a provincial health number in each province, and there's a few additional federal ones. So there's 14 or so, 15 or so identifiers that are pretty consistent across all systems, and a lot of the registries include mappings. So the BC patient registry will know the Alberta patient identifier and vice versa if somebody has established a linkage. And so that works. But that's not a FHIR problem, that's a human problem. You actually have to have the organizations agree on a common identifier that they want to use. And if you have that agreement, or there are some countries where there's a national person identifier that gets used for taxes and healthcare and everything else. And if you've got one of those, awesome. And if you don't have one of those and you have regulations that prohibit you ever introducing such a system, the US is in deep trouble because they have strong political reasons to push back against having national patient identifiers, and because of that, they have patient matching issues. And FHIR doesn't make that problem go away. You still have to leverage the real world identifiers that you have, as good quality as they are or as poor quality as they are. Some are obviously better than others, but you need to land the discussion of how do you identify. FHIR just gives you a technical mechanism to share the identities that exist. Question on, can you use Unicode? Yes, absolutely. So there is no problem using any of the Unicode characters, and if you dig into the patient examples enough, you'll actually see some. I think we've got some Japanese and some others. We don't have any Israeli examples as yet, so if you want to contribute some of those, we would welcome including those in the core publication. Just make it obvious that, hey, yeah, this is possible and this is what it looks like. But yeah, full Unicode support, both in the specification and also in the reference implementations. By the way, one thing that I did not show in the core specification is that it is possible to publish translations of FHIR. I'm not sure that that's going to be a super important thing in Israel, because I suspect most of your software developers are pretty conversant with English. Actually, I'll go to the official spec. but there are some places that have created language translations, and if you want to do that to Hebrew, we can talk offline and I can tell you how to do that. So that is also a possibility. Last thing we're going to talk about with respect to EPIC is how do you manage versioning? So let me bring EPIC back up.
Lloyd, you missed a part of the question regarding.
Oh, sorry.
Hebrew is right to left, not left to right.
Oh, sorry. Yes.
Is different.
So, I mean, FHIR, in terms of the syntax, is XML or JSON. And so it will take whatever content you give it. There's nothing intrinsic in terms of how it gets rendered. So if you have a string and it declares that the language is Hebrew, then you can choose to render it from right to left. So the information about what language either the resource as a whole is in, or what language a particular string is in, there's an extension that allows you to identify the language of a string. That should give your rendering tools enough information to render it appropriately, whether left to right, right to left, top to bottom, or bottom to top, depending on the language in question. But there's nothing intrinsic in the FHIR format itself that is ordered. I mean, the JSON and the XML, there is expectation that arrays are retained so that names continue to be in the order that they're listed, and address lines are in the order that they're listed. In XML, the properties also need to appear in a particular order because schema likes that. But beyond that, there's nothing specific in FHIR that makes it ordered, and it would be up to the rendering tools to render things appropriately. Obviously, if you are sending data to a healthcare piece of software that doesn't understand how to render content properly for a given language, then it will just dump it to the screen, and it may not look right. But I'm sure you're used to that with all sorts of other applications. And it's really a question of the software system to make sure that they get the rendering right. In terms of implementation guides, we have not yet explored making sure that our implementation guide templates handle non-left to right languages well, but there is a template mechanism where you can define your own templates, and we should be able to create a template for you where you can plug in your content and everything will flow appropriately, because it's all driven by HTML, and of course HTML knows how to render a variety of language styles and directions. Did that better answer the question?
Guy, it was your question.
All right. All right, so I have to log in one last time. And I just want to take a look at one more set of information in the patient resource. And that is this. So as you've seen, EPIC supports R4 and STU3 and DSTU2. And the way it does that is they actually have a different endpoint for R4 patient than they do for STU3 patients. So here you can see interconnect-FHIR-OAuth API FHIR R4. And if we go back to the API list, and let's go up here and search. And go take a look at their STU3 interface. And take a look at the raw request. You will see that they have a separate endpoint for STU3. So that is one approach to managing multiple versions of FHIR, is that you stand up separate REST endpoints for each release that you support. And then each of those interfaces in turn maps to your internal persistence layer. In some cases, they might all map to a single version of FHIR, and then that version of FHIR maps to your persistence layer, or they might each map to your persistence layer independently. It sort of depends how you prefer to do your maintenance and how much overhead you want when working with different versions of FHIR. There is, however, as of R4, an alternate approach to managing versions. And that, if we go to the documentation page in the FHIR spec, in the section on managing multiple FHIR versions, there is an ability to use HTTP content negotiation. So in addition to saying, I want back FHIR JSON, you can also say, I want back FHIR version 3. And as with any other HTTP content negotiation, you can list multiples of those. So I prefer release 3. If you can't give me that, then I'll take STU2. If I can't get that, then you can't talk to me. And so that approach allows you to send up a single interface and just use the MIME types and content negotiation to determine what version it is you get. And we already looked at the maps that exist on the resources to handle resource conversion. We provide those as part of the specification. Sometimes the mappings don't work because there's been enough of a change between the two releases that there's just no way to transform. That's sort of what life looks like when the standard is still evolving. But most of the key parts of the standard are now pretty stable, and I would expect that things should map pretty cleanly between release 4 and release 5 for most of the common resources, at least. And the last thing we're going to take a look at in Epic is security. So if you looked at the Epic interface, first of all, you'll notice that cool little lock icon. So all of these calls that we're making are over HTTPS, as shown there. So it'll check to make sure that the certificate is valid. It's possible to do mutual TLS with FHIR, although you have to have certificate architecture set up to make that happen. The other thing that we have here is our OAuth token. So that conveys to Epic who the heck is asking. And behind the scenes, Epic will be capturing audit log events of all of my queries tied to my user account based on this OAuth token. And there's nothing different in this OAuth token structure than would be used with Facebook or Google or any other similar system that works that way. If we go back to our documentation, there's also a whole module in FHIR on privacy and security that talks to various things like how do you represent consent in FHIR, and how do you capture audits, and how do you do digital signatures, and how do you anonymize data or de-identify, and what are all of the security things that you need to think about when managing access and all of that kind of stuff. So I could spend half a day just talking about all of this stuff, but the key point is that it's there. for you to wade through. And there is a security stream on Zulip as well. So if you run into stuff that is not well documented there, or you're doing something that's a little bit more esoteric and want to ask the experts, there's a place that you can go and do that. Any last questions before we transition from Epic to our next scenario? That one was a little long, I realize. I'm going to just touch on the next one. We're not going to get through it. We'll continue that tomorrow. But any last questions on the sort of the basics of REST and the basics of FHIR? While I wait to see if anything comes in. Next thing we're going to talk about is US Core. US Core is the first implementation guide to exist in FHIR. And implementation guides are the way that we take that base FHIR standard that is generic to all countries, all healthcare disciplines, all use cases, and tighten it down to reflect the needs of a particular space. So US Core obviously is US specific. And we're going over it not just because it's the first, but also because it's a pretty strong driver of the capabilities of many of the major international EHR systems, because the US is such a significant market, and also because they were one of the first movers in the FHIR space. They have sort of set the pace and the direction for a lot of EHR support. So we're going to talk about a few things. First of all, how to find implementation guides in the registry. We're going to talk about how to read profiles. We're going to talk about a special property in profiles called must support. We're going to look at terminology and bindings. We're going to look at capability statements, so how systems define what it is that they do, or how implementation guides define what systems are supposed to do, and how you can go off and define new search mechanisms. So if we go to the FHIR specification again, and go back to that home page. Down at the very bottom on the left, there is a list of implementation guides published by HL7 and affiliates and FHIR Foundation members. And sorting here is a little bit odd. It's actually sorted by when did the implementation guide actually get created. So US Core was the very first implementation guide ever created. And you can go back and see all the different versions, including the continuous integration build version, where they show the brand newest stuff, but isn't necessarily stable. We'll take a look at their stable release. And there's standard technology to publish all of these. This gives you an introduction of what the heck the implementation guide is covering. And essentially, these are the profiles that the major US EHR vendors have decided to support. So they can handle allergies, they can handle care plans, they can handle lab observations, practitioner, pulse oximetry, et cetera. A lot of this is actually regulatorily driven. So there is a minimum data set that the US government has published that says you must be able to expose via a standard API this set of patient data. And oddly enough, probably 95% of the resources that are listed here are those that are relevant on that minimum data set. So if we go take a look at the patient profile here, and we scroll down, we see that, first of all, they've defined several extensions, and those are the extensions that we saw previously in Epic. And they've said that they are must support. What that means is, even though they are optional, you don't have to include race and ethnicity and birth sex in every single patient instance that you share. You must be capable of sharing that information. You must be capable of capturing it and storing it and making it available. And if you claim to be conformant, then you're expected to be able to consume it and understand what it means and do something useful with it. In terms of identifiers, they've tightened this up. They said that instead of 0 to star, it's 1 to star. So if you want to be conformant with US Core, you have to have at least one identifier. And while identifier supports period and type and various other things. They say, we don't care about those. If you have them, fine, they're not prohibited, but you have to have a URI, you have to have the system, you have to have the value. So you can't just send the identifier string, you have to send the identifier system as well. Similarly, they're dealing with an identified patient use case. And so they say that you have to have a name. So their use case does not cover the unconscious patient sitting in the emergency room. They're dealing with sharing information to patients, and presumably in that circumstance, you know who the patient is, and name will be present. And so they've gone through and done that same thing. You have to support telecom, specifically these values. You have to support gender, and that's mandatory. You have to support birth date, and that's not mandatory. You have to support address, and these are the particular elements within address that you have to support. We can then take a look at this within the scope of the overall patient resource, and that makes it more obvious what are the things that you don't have to support. So you don't have to support the identifier type or use or period. You don't have to support prefixes and suffixes in names. You don't have to support deceased date at all. You don't have to support district or country within address. You don't have to support multiple birth numbers or marital status or any of the contact information. All of that is still allowed. We haven't constrained any of that out. We'll see other profiles tomorrow where they have. But this gives you a sense of what an implementation guide looks like and how to read that. So we will continue drilling into US core tomorrow, and then we will jump to some of the other specifications. 2 hours goes fast. Thank you all. If you have additional questions, feel free to jot them down and we can take them up at the beginning of our session tomorrow afternoon.
Great. Thank you very much, Lloyd. I enjoyed it very much and learned a lot. I hope everybody did. As Lloyd said, if you have any questions or feedback from today, please feel free to contact us or Lloyd, and we'll try to speak about them tomorrow. So happy to see you here and see you tomorrow. Bye-bye.
Thank you very much.
Good night.
Bye-bye.